All right, let's dive right in. Today, we're tackling a fascinating clinical mystery, one that literally hides in plain sight. We're going to uncover how something as simple as a person's height can be directly connected to a sudden, life or death emergency.
So picture this. You've got a young, tall, really slender patient who comes into the clinic, maybe for something totally unrelated. And then out of absolutely nowhere, they're hit with this severe, tearing chest pain, the kind of pain that makes everything stop. Right away, you know the stakes are incredibly high. And this isn't just bad luck. It's a huge, flashing clue.
And that leads us to the central puzzle we're going to solve today. I mean, how on earth can a person's height, or how long their fingers are, have anything to do with a catastrophic heart problem? They seem like they're from completely different worlds, right? But the answer, well, it pulls back the curtain on a fundamental secret about how our bodies are actually built.
To really get that connection, we have to look deeper. We're talking about the body's basic construction materials, the blueprint itself. Because this whole story, it all starts with a tiny error in a single gene.
The condition we're talking about is Marfan Syndrome. Okay, that sounds like a mouthful, so let's break it down. Autosomal dominant. That's just a fancy way of saying you only need one copy of the faulty gene from one parent to get the disorder. And connective tissue? Well, that's pretty much what it sounds like. It's the body's glue, its internal scaffolding. It gives strength and flexibility to, well, everything. Your skin, your bones, your blood vessels, even your eyes. So here's the chain reaction, the domino effect, at the very heart of the syndrome. It all begins with a little mistake, a mutation, in a gene called FBN1. That gene is supposed to be the instruction manual for a protein called fibrillin-1. So if the gene is messed up, the protein it makes is going to be messed up too. And since fibrillin is a super important part of our connective tissue, the body's whole scaffolding just becomes weak and unreliable. Now, a single genetic flaw like this doesn't just stay in one spot. Nope. Its effects ripple out through the entire body, leaving a trail of really distinct clues for us to find. So let's put on our detective hats for a minute and follow the evidence. We're going to focus our investigation on three main areas: the skeletal system, the eyes, and, this is the big one, the cardiovascular system. You can think of this as our diagnostic checklist. If we carefully check each one, we can start to piece this whole puzzle together. First stop, the skeleton. Because that connective tissue is weak, the bones kind of overgrow, which leads to that classic tall, thin body type. And one of the most famous signs is something called arachimonoctyly. It literally means spider-like fingers, because they're so unusually long and slender. You know, doctors have these two really simple physical tests they can do. With the wrist sign, the person can actually wrap their hand around their other wrist, and their pinky will completely overlap their thumb. And with the thumb sign, if they make a fist, their thumb sticks way out past the side of their hand. Both of these are pointing to those long bones that are so typical of Marfan syndrome. Okay, next, let's look at the eyes. That same weak connective tissue affects the tiny little ligaments that hold the lens of the eye in place. In Marfan syndrome, those ligaments can get stretched out or even break, causing the lens to shift out of place. This condition is called ectopia lentis. And now we get to the most critical clue, the one that explains that terrifying chest pain. The aorta, right? It's the main highway for blood leaving the heart. Its walls are full of connective tissue to keep it strong. But in Marfan syndrome, those walls are weak. So over time, the constant pressure from the heartbeat causes the aorta to stretch and bulge. That dangerous situation is called aortic root dilation. And this is the point I really need to drive home. While the long fingers and eye problems are important clues, it's the cardiovascular stuff that makes this condition so incredibly dangerous. That stretched out aorta is basically a ticking time bomb. It's at high risk of tearing, which is called an aortic dissection, and that is a massive medical emergency. Dealing with this risk is job number one. So once we've gathered all these clues from the body, a doctor can start to solve the puzzle. But, and this is a big but, making the right diagnosis also means you have to rule out other conditions that can look pretty similar on the surface. And this isn't just guesswork. There's a formal, systematic process using a checklist called the Ghent criteria. This system is really clever. It combines the patient's family history with all the specific findings in the skeleton, the eyes, and the heart that we've been talking about to land on a definitive diagnosis. Now here's a really great little clinical pearl, a key exam trick for telling Marfan syndrome apart from a lookalike condition called homocystinuria. Both can cause that dislocated lens we talked about, but the direction is the giveaway. In Marfan, the lens tends to pop upward and outward. In homocystinuria, it goes downward and inward. It's such a subtle difference, but diagnostically, it's huge. Okay, so once the diagnosis is confirmed, the entire focus shifts. We move from identifying the problem to creating a proactive action plan. The goal now is to actively manage the condition to prevent that disaster we've been talking about.
And the strategy has a few key parts. First, you've got medications like beta blockers and ARBs, which lower the blood pressure and just reduce the day-to-day stress on that weak aortic wall. Then, patients get regular echocardiograms, basically ultrasounds of the heart, to keep a close eye on the aorta's size. And if it gets too big, beyond a certain point, surgeons will step in and proactively replace that weak section before it has a chance to tear.
And that brings us right back to where we started. The whole point of all of this, the diagnosis, the monitoring, the medication, is to get ahead of the problem. It's all about preventing that catastrophe we imagined at the beginning, the aortic dissection. It's about turning a potential emergency into a chronic condition you can actually manage.
So if you remember just one thing from all of this, make it this simple triad. When you see a patient with that tall stature, a dislocated lens, and you find a dilated aorta, you absolutely have to think Marfan syndrome. That's the core pattern, the thread that connects all the clues.
And that kind of leaves us with one final thought, doesn't it? What Marfan syndrome teaches us is that so often the most critical diagnostic clues are sitting right there in front of us, in how tall someone is, in their hands, in their eyes. The real challenge, and maybe the real art of medicine, is just knowing to look, and then seeing the life-saving connection that's been hiding in plain sight all along.